So autoimmune diseases would be of two spectra. The local ones, the ones that attack specifically maybe a particular organ, and we have those ones that are systemic, that would affect the entire body. Now, examples of those that are fairly difficult to differentiate between the ones that are local and the ones that are systemic, because in most cases you find that a disease is affecting a particular organ, and that organ definitely fits within a certain system, and that system links to another system. So again, it's neither here nor there. But I think in this case, let us just say the ones that focus on a specific organ would be local, or rather specific autoimmunity, organ-specific autoimmunity. And then we have those ones that maybe will target an entire system, would say that those then are systemic autoimmune diseases. Now, example is the thyroiditis, the Hashimoto thyroiditis, of course, that attacks the thyroid gland. Pernicious anemia, we know that which particular cells are being affected here, the red blood cells. Now, pernicious anemia is different from the rest of the anemias because in this case, the genes or the cells that are producing intrinsic factor is the one that is needed for the production of vitamin B12. And vitamin B12, we know that how important it is, especially for red blood cells and anemia. We know how important that is. Now, these antibodies or autoantibodies attack cells that are supposed to produce intrinsic factor. And when that happens, then of course, you end up having anemia, but a type of anemia called pernicious anemia. I know we have different types of anemia. We have sickle cell anemia, we have sideroblastic anemia, we have now pernicious anemia. We have different types of anemia. So this particular anemia is autoimmune, similar to thyroiditis, and this I think must have been discovered by Hashimoto, so it's called Hashimoto's thyroiditis, where of course the thyroid gland becomes inflamed because antibodies are being generated against it. So that of course would even influence the hormones that the thyroid gland produces. So it affects the functionality of the thyroid gland. And we know that the thyroid gland has major functions in the body. And so that's the reason why I was saying, like, even if it's pernicious anemia, even if it's thyroiditis, it's difficult to distinguish between what is systemic and organ specific, because if the thyroid gland is affected, then most likely, of course, the entire body is going to be affected. Similar to if red blood cells have been affected, then definitely the entire body is going to be affected somehow. Although we are now just focusing on this to state them that they are organ specific, while systemic lupus erythematosus would be more or less immune complexes. And the immune complexes here, remember, would be an antibody antigen complex. It is also possible to have an antibody antigen complement complex. Those are what we are calling immune complexes. Those are the most common immune complexes. So antibody antigen bind, form a complex, of course. It is also possible to have an antibody antigen binding to a complement. We know what complement is. And these then are deposited in different parts of the body. The deposition, of course, especially in the blood, brings about what we call serum sickness. And that is what usually affects people with lupus. We commonly, of course, refer to this condition as lupus. So most patients with lupus are affected by this. Okay, so then this would be how we classify these autoimmune diseases, either being organ specific or being systemic. Now let's look at some of the factors that influence these conditions. Some of the factors that influence our autoimmunity. And we can generally classify them as either being genetic factors or environmental factors. What are some of these influences? Now we have genetic factors. And genetic factors would be what we refer to as the HLA tissue, the HLA of an individual. So some HLAs or human lymphocyte antigen have been linked with certain autoimmunities. Certain diseases have been linked with an individual having a specific HLA. Now, can anybody remind us what we mean by an HLA? What is HLA? What we mean by HLA, this human lymphocyte antigen, what do we commonly refer to as in the body? If somebody, for instance, is supposed to undergo transplant, an organ transplant, you have to type HLA of this individual. If they have to undergo bone marrow transplant, of course, this is fairly common nowadays, especially for people with genetic diseases like sickle cell. They have to do a typing of the HLA so that we understand their genetic makeup of the HLA, their HLA. Yeah, so HLA is what we commonly refer to as MHC. And how many types of MHCs do we have? How many types of MHCs do we have?
Two.
Two? Steve says two. Are they two? Two? Those are the only MHCs. Miguel says three. MHC, who's the other MHC? Yeah, so I think when we were discussing the major histocompatibility complex, we said that we have three types of MHCs, 1, 2, and 3. And MHC1 interacts with CD8, of course, in antigen presentation. MHC2 interacts with CD4 in antigen presentation. Then we have an MHC3 that has no immunological functionality, but it does exist. So we have three types of MHCs. So immunologically, yes, we might have two, but the body, the area we are calling the area of genes that code for MHCs are three. So that MHC is generally what we refer to as the HLA. HLA. So human beings are classified into different types of HLAs. Now we have, I don't want to go into the nomenclatures of HLAs. Don't want to go into the nomenclatures of the HLAs. But it's just important for you to understand that we have different types or types of HLAs. Now, for instance, we have HLA-DR, we have the HLA-DQ, we have HLA-DM, we have HLA, different types, as I'm saying. Now, individuals who happen to have HLA-DR part 4, or rather 4, HLA-DR4, are likely to end up having rheumatoid arthritis. So you might be HLA-DR and you might be specifically HLA-DR4. It does not necessarily mean that you'll end up having rheumatoid arthritis. It's just that majority of the individuals who end up having rheumatoid arthritis have HLA-DR4. Then HLA-DR2 has been seen in individuals with multiple sclerosis. Yeah, that has been seen, or rather typed. Then we have individuals with HLA-DQ, of course, and HLA-DQ8. HLA-DQ 2 and 8 they've been described in celiac disease as well as type 1 diabetes. When type 1 diabetes is where these individuals, what is happening for these individuals is that the body is producing autoantibodies against the beta cells. So there is insulin deficiency in these individuals, but not because of, say, if it's insulin resistance, then that might be, say, type 2 lifestyle diabetes mellitus. But in this case, the cells that are supposed to be producing insulin are being attacked in the islets of Langerhans, of course, in the pancreas. So that's what is happening for such individuals. And it's been found that they have an HLA type that is DQ. That's the HLA type they carry. So not going to the typing of HLAs, what it means is that they just have a different genetic makeup to other people. They have a different genetic makeup to other people. Yeah, so that is what we mean. So in terms of their MHC or rather the HLA. So that is the genetic association. So we have some people with certain HLA that so there is evidence to show that a majority of those individuals might end up having a certain type of autoimmune disease. So does it mean that we can find an individual, say, who has rheumatoid arthritis and their HLA-DQ? Yes, it's possible for that to happen, but there are not as many as those who have HLA-DR. Similar to multiple sclerosis, similar to type 1 diabetes or celiac disease. Actually, even HLA-DQ in people with type 1 diabetes is just about 40% of these individuals who end up having, who have DQ, who end up having type 1 diabetes mellitus. Then we have the gender issue. Generally, females have a higher likelihood of ending up having autoimmune diseases compared to male. And the difference is the hormonal issues, the hormonal influences. So because of the different hormones that may be present, women are more to having autoimmune diseases compared to men. If you'll be dealing with these patients, of course, you're going to deal with these patients as you practice your clinical aspects in nursing. You'll find that quite a number of people presenting with, say, rheumatoid arthritis, which is common, of course, in this part of the world, are going to be female. Older women, above 50, they are going to end up, so the rate at which women present with rheumatoid arthritis is going to be higher than men. And quite a number of these other, even lupus, you'll find that majority will be women compared to men. So that happens because of the reason is their hormonal influences. Then we have environmental factors. So these have been really studied even in identical twins. This has been studied even in identical twins. You can find identical twins who have a genetic predisposition to, say, type 1 diabetes. They all have that predisposition. But when you put them in environmental conditions, find one manifests and the other one does not. Yet they have a similar genetic makeup, especially identical twins have an almost 99.99 match in their genetic makeup. So how come that one ends up having this condition and the other one doesn't? What it simply means is that the environment has a lot of influence. Now, we've seen scenarios where I think we were discussing the previous, when we were looking at immunity to parasitic infections, we saw that somebody being infected with, say, Trypanosoma cruzi ends up having a Chagas disease. And Chagas disease is is an autoimmune disease because of the cross-reactivity between assess your antibodies. So these super antigens that exist on these parasites trigger an immunological response, a humoral response of antibodies that are generated. And these antibodies cross-react with human antibodies and then start producing auto antibodies. For the Chagas disease, we saw that these individuals end up having cardiomyopathies. So the environment really triggers. We have some pathogens that will bring about even molecular mimicry, where they mimic the body. So they produce antibodies that are similar to those. And when that happens, then it triggers an autoimmune disease of an autoimmune reaction. For to a big extent, people are usually discouraged from taking cow milk. To a very big extent, cow milk has a predisposition of this. So yes, of course, the body is able to detect milk. Milk could have proteins in it, of course. So these proteins that are carried in milk, they kind of are similar to some human proteins. And when antibodies are produced against them, there is what we call molecular mimicry. So the way the antibodies are being generated against milk proteins versus human antibodies, there is an almost similarity. And therefore, you see, if that is happening, then these antibodies, are they being produced to attack these foreign milk antibodies? But in the process, since they look like the human antibodies, they attack the immune system and trigger an autoimmune response. So there's a risk between consuming not human milk, consuming cow milk and autoimmunity. There is that risk to a big extent. So of course, the results are not very, very conclusive, but there is a similarity between how antibodies against milk versus some antibodies in the body. So there's a risk of an autoimmune condition developing when you are always constantly consuming cow milk. And this could be prevalent in some people and not others. And especially, I think people who have an autoimmune disease already, one of the things they are told is maybe they are discouraged to use cow milk. That usually happens. They are discouraged from using it. And that is part of the reason that we are calling molecular mimicry. So what are some of the mechanisms of autoimmunity? So the mechanism for which autoimmune conditions use, one is autoreactivity, and that is the main one, autoreactivity. So, of course, the circulating autoreactive T and B cells controlled and regulated by CD4 and CD25 T cells. So they express CD4 and CD25. And most of these cells, of course, are T regulatory cells. Cells that express CD25, and then they express FOXP3. If you remember, they express FOXP3 as a protein. They also produce interleukin 10 in large numbers. Even TGF beta, they do produce TGF beta. These cells are called T regulatory cells. So if these cells are not enough, if there is scarcity of this type of T cells, then there is a likelihood of an autoreactivity. And when that happens, then autoimmunity would be triggered. The other thing is controlled by T helper cells. Of course, so autoreactive T helper cells are usually unresponsive. They are unresponsive, and it might lead to clonal deletion, clonal energy, T suppression, of course, an inadequate autoantigen processing. So clonal energy would be the way an antigen interacts with T cells, and then it's enabled because of we remember antigen presentation needs co-stimulation. Antigen presentation needs co-stimulation. We talked about two co-stimulatory molecules that are supposed to be present for then that to happen. Can someone remind us the two co-stimulatory molecules in antigen presentation? There are two molecules where antigen presentation has to happen.
CD28 and CD8.
yeah, CD28 and CD80. Those are. So when antigen presentation is not done via these two molecules, what usually happens is that there will be clonal energy, and therefore no no specific antibodies are produced in this case. So that is what we mean by energy. So if there is a scenario whereby these T helpers are unable to really link T cells and B cells, that then of course triggers autoimmunity. And then another way is bypassing this regulation, because an immune response needs to be regulated. But if there is a way in which there is a bypassing of the regulation, and we saw that T regulatory cells are playing a very key role in regulating the immune response, then of course then that triggers a scenario whereby autoimmunity is going to develop. And that would be as a result of, say, new determinants, so autoantigen modifications, where say there is a synthesis or breakdown or drug interactions or cross-reactivity that usually then activates T cells. And this is from a new thing, an antigen that has not been seen before. If that is happening, another scenario would be if the Fas and Fas ligand, so Fas is a receptor and Fas ligand, if the two, the interaction fails, if the interaction of the Fas ligand and Fas fails, then that then of course would lead to deletion of T cells, because T cells have to interact via the Fas ligand. If that then fails, then it will lead to deletion of T cells. And it means this thing we are calling clonal deletion will happen. It means there's something wrong with these T cells that are being produced. Yet those T cells were maybe being generated against specific antigens, of course, in response to specific antigens. So there was clonal expansion, but interaction between Fas and Fas ligand, because Fas and Fas ligand means that you need to proliferate these cells. If that interaction is not happening, then it means those cells are going to be deleted, and then the immune response, of course, will not be enough to regulate the autoimmunity. Then we have interleukin-2, and interleukin-2 usually plays a key role in activation of apoptosis. There are molecules called caspases that then play a key role, of course, in ultimately apoptosis. But if then they are not, interleukin-2, sorry, is not produced, and there's a deficiency in it, or somebody has a mutation that triggers maybe interleukin-2 not to be produced in adequate numbers, they are likely going to end up having autoimmunity, because the regulation fails. Regulation fails. But the main mechanism is usually when individuals are unable to adequately produce T regulatory cells. If that happens, then these individuals are likely to end up having an autoimmune disease. So then what is the damage that then autoimmunity does to the body? What damage is triggered? One of the damages, of course, is humoral autoantibodies. We know that is the humoral system that then produces antibodies, and these antibodies are autoantibodies. They are self-antibodies. So they target things like blood, they target surface receptors, they target other tissues, and there could be even passive transfer through maternal IgG that would then cause or short-lived fetal disorder. So we can have scenarios whereby the newborns have an autoimmune response, but it's short-lived just because of maternal IgG. Of course, ultimately ends up born. And when that happens, and they happen to be autoantibodies, they might trigger an autoimmune response, but that is short-lived. But the key thing is the immune complexes. The immune complexes, which we said These immune complexes can possibly be antigen-antibody, antigen-antibody complex. Those are the immune complexes that majorly exist, and they would be deposited in various organs. This would include the kidneys, the skin, the joints. If the all organs that are being say these immune complexes are being deposited, then most likely this individual is going to suffer from SLE, systemic lupus. They have the position of these complexes in most organs of the body. They end up having systemic lupus. So of course, then there is inflammation in these organs and lesions also these organs. And that of course then causes these individuals to suffer from the condition. Then we have quite a number of conditions, of course, that are mediated by T-cell hypersensitivity. So they are autoimmune, actually a majority of the autoimmune diseases are T-cell mediated. They are T-cell mediated. So this is a hypersensitivity that is T-cell mediated in this case. Now, an example is type 1 diabetes mellitus, and we saw the reason why there's an attack to the insulin producing cells, sorry, that is what is happening. So T-cell destruction of pancreatic beta cells. So T-cells are the ones that are triggering the destruction of these beta cells in the islets of Langerhans. That is what is happening for people with type 1 diabetes mellitus. Now, for people with multiple sclerosis, is T-cell and macrophage induced demyelation. Now we know that myelin sheath, how important it is. So T-cells are attacking the myelin sheath in the neurons of these individuals. But also macrophages are also attacking. Now, for individuals with rheumatoid arthritis, what is happening is activated T cells and macrophages release interleukin 1, interleukin 6, tumor necrosis factor should be alpha because these seem to be all pro-inflammatory, and enzymes that cause joint inflammation. So that is what is happening. So T cells and macrophages are triggering on joints specifically. These joints are the ones that are being affected here. And of course, for you to be effective in treating these individuals, you're either using an anti-TNF therapy or CTLA4 immunoglobulins. So antibodies that are generated against CTLA4 will then also be effective against these individuals. Then we have Crohn's disease. Here there is T-cell infiltration and cytokine activity, of course. So that is what is happening for individuals with this disease. And when you want to, what you'll be targeting maybe is TNF also, just almost similar to rheumatoid arthritis. What you'll be targeting is tumor necrosis factor alpha. No, gamma is the most. Then celiac disease. These individuals have T-cell response to gliadin. Then, of course, they are also going to produce an anti-transglutaminase antibody. So they are producing antibodies, autoantibodies against transglutaminase. This enzyme is what they are producing against. So it has T-cell response. Then we have thyroiditis, that is Hashimoto. Here there is cytotoxic T cells and cytokine-mediated thyroid destruction. So again, T cells are being involved in the destruction of the thyroid gland. So T cells play a major role in autoimmunity. As we've seen, most of the autoimmune diseases fall under that category where T cells are the ones that are playing the role. So a number of them, of course, are just resulting from IgG or immune complexes being generated, but quite a number being as a result of T-cell interaction. Now we have atherosclerosis. In atherosclerosis, we have mononuclear cells and cytokines that cause smooth muscle proliferation and plaque formation. Then for psoriasis, Th1 cytokine induced keratinocyte hyperproliferation. So keratinocytes are overproliferate in this case, and that's why then it triggers them, patients appearing the way they do, like people who've been burnt or their skin has been burnt. Of course, it's also a T cell mediated autoimmune response. So how do we diagnose this So the most common way of diagnosis, of course, is to measure serum autoantibodies. That is the most common way. So it's fairly easy to detect if an individual has an autoimmune response, an autoimmune disease. These individuals would definitely have autoantibodies in their serum. The autoantibodies they are self-antibodies, maybe against a specific organ or against a specific system. And so with an RDT, a rapid diagnostic test, that is the antibody antigen test, it's very easy to detect. And all you are doing is just measure the serum antibodies and you're able to detect them. So treatments, how do you go about treating? Some of them, of course, we've touched on them, but conventional therapy is you control the metabolic pathways, of course, and you also control anti-inflammatory. So you use immunosuppressive drugs. You use immunosuppressive drugs so that you want to lead to a scenario whereby T regulatory cells are being generated in large numbers. That is how you target. Sometimes you can also do what we call plasma exchange. So you use antimitotic drugs to remove pathogenic antibodies. You can also inject intravenously immunoglobulins that are specific against an idiotype. You inject them with antibodies that are against the idiotype that has been produced against a specific antigen. So the self-antigens, you are producing antibodies, against self-antigens. No, against self-antibodies, because these autoantibodies are self. So you're producing other antibodies against them, now that they are proteinous in nature. And also, remember, there is cytokine production in this case. So you also produce anti-cytokines. These cytokines that are going to trigger this inflammatory response. You produce what will neutralize these cytokines. For instance, if they are pro-inflammatory cytokines, what is going to neutralize the pro-inflammatory cytokine is likely going to be an anti-inflammatory cytokine. So if there's a lot of IL-6 being produced, then definitely you can neutralize it by having these people injected with lots of interleukin-10 and lots of TGF-beta to neutralize the activity of pro-inflammatory cytokines. That is what will happen in that case. So we have things that are still under study now that possibly could be therapeutic solutions in the future. So T-cell vaccinations, that is a possibility. Then these are studies being done in mice. They've been so far successful, switching from Th1 to Th2. Yeah, that of course you remember we talked about something called the hygiene hypothesis, where maybe people who are living in conditions that are not very hygienic are prone to Th1, while those who are living in hygienic conditions are prone to Th2. So when you switch from Th1 to Th2, there's a likelihood of reducing people ending up having autoimmunity. Then inducing antigen-specific T-cell and responses using peptides, that is also being under trial now. So also biologic agents targeting cytokines, adhesion molecules, or receptors. Like you've seen how IL-2 plays a key role here. CD40 ligand Then TNF blockade, you can target TNF to block it, especially for rheumatoid arthritis, as well as other autoimmune diseases. So these are some of the ways or some of the methodologies, or rather things that are being currently under study to be able to deal with these autoimmune diseases. And that, of course, then brings me to the end of this course and this discussion today.